We are now with the last set of slides, and that is inhibitors of translation. And we're going to have two VOPs for that. We start with aminoglycosides, and then the next VOP will be for other inhibitors of translation. As usual, I think you know by now, in every set of slides, we talk about mechanism of action, broad antimicrobial spectrum, we talk about pharmacokinetics when applicable, and for aminoglycosides, by the way, there is a very nice pharmacokinetic application that we'll talk about, and then common or serious side effects. I highly recommend that you go to this YouTube movie and refresh your memory concerning bacterial protein synthesis. I'd like you to remember that we have the ribosomal subunits, the large subunit and the small subunit, and then how they come and attach to the messenger RNA so that we have an elongating protein chain, and how we have an acceptor site, a protein site, and an exit site. Please refresh your memory for that so that it's easier for you to understand the mechanism of these antimicrobial. What we'll be covering, so in this voiceover PowerPoint I will be covering aminoglycosides, and in the next ones I'm going to cover the ones highlighted in green: tetracycline, followed by oxazolidinedione, linezolid basically, chloramphenicol, clindamycin, and macrolides. I will not talk about glycylines and streptogramins in details. However, I want you to remember that this class, and that drug, linezolid, all three are for VRE. What is VRE? Vancomycin resistant enterococci. So remember, what are we using vancomycin for? We're using vancomycin for MRSA. And now if we have vancomycin resistance, which would be really bad, well, at least we do have some options here or here or here. Also, I want you to realize that there is some site specificity. For instance, aminoglycosides, tetracyclines that we will be talking about work on the small ribosomal subunits, whereas the others that I will be talking about work on the large ribosomal subunits. Good, so let's start with aminoglycosides, and I want you to know that aminoglycosides are bactericidal. So far, if you remember what we have covered, almost everything we talked about is bactericidal except for sulfonamide and trimethoprim. And aminoglycosides are also bactericidal. So you can guess from the name, those are aminoglycosides. So what do we have here? We have two amino sugars that are joined in a glycosidic linkage to an exose nucleus. Okay, so we have aminoglycosides, and the three typical aminoglycosides that we talk about are gentamicin, tobramycin, and amikacin. Mechanism of action, remember we said that we are going to inhibit the small ribosomal subunits. We said aminoglycosides and tetracycline do that, and the rest that we will talk about are inhibit the 50 ribosomal subunit. Well, what happens here is that we have binding to the 16S ribosomal RNA in the 30S, and if you watch the YouTube movie you remember that. So the antimicrobial will bind to it, and because of that there is inhibition of binding of the correct transfer RNA to the messenger RNA. So we do not bind the correct one anymore. So what can happen because of that? So we have a growing polypeptide, you add the aminoglycoside, it binds to the 16S, here you go, here and here and here in the small ribosomal subunit. So what could happen if this starts in the beginning before we even have a growing polypeptide? Well, this can block the initiation of protein synthesis, so we have no protein at all. Now, if we already have a growing polypeptide, it can block further translation. We may have a premature termination, or probably the most common, we already have a growing polypeptide, we have misreading, and hence we incorporate an incorrect amino acid. So we either have no protein, we have a premature termination of the protein, or we have protein but with incorrect amino acids. We have been talking about selective toxicity a lot. Of course, we eukaryotes have ribosomes, however, ours are different from the prokaryotic one. Our ATS ribosomes do not bind aminoglycosides well. Also, our cells do not transport aminoglycosides. I failed to mention that aminoglycosides are polar compounds and hence they need active transport into the cell. So this doesn't happen in our cells except in two areas, and that is the proximal convoluted tubular epithelia and the inner ear epithelia. And I think by now you can guess what kind of toxicity we have with those antimicrobials if they concentrate in the kidney and in the ear. And as a matter of fact, I want you to think of this question. Let's see. Yep, vertigo. Abnormal liver function test. I didn't say anything about the liver. Increased hearing ability. No, if anything, it's gonna be decreased hearing ability. Increased GFR. No, if anything, it's gonna be decreased GFR. So yeah, those drugs are associated with vertigo. Now, we said that this is bactericidal. We understood the mechanism of action, the inhibition on the 30S. We said that we're going to have no protein or cut protein or the wrong amino acids. So what? So what's happening here is the misreading of the genetic code, incorrect amino acid, and this is going to happen everywhere. Specifically, we're interested in the cell membrane. We're going to have an aberrant cell membrane protein. This will disrupt the cytoplasmic membrane, and then we'll have leakage of ions and large molecules, and this will lead to cell death. So this is the most common mechanism for aminoglycosides bactericidal effect. Microbial resistance, we always have a slide on that, and what we list on those slides is what we have the most common. So ribosomal mutations can happen, but this is rare. Transport mutation, this can happen, but it's rare. The most common is enzymologic modification, and that reminds me of what? Of the beta-lactams and the beta-lactamases. And the enzymologic modification here is acetylation, adenylation, and phosphorylation. Let's go over this slide. So here we have 4 aminoglycosides: gentamicin, tobramycin, netilmycin, and amikacin. And what you have here are sites that are potentially enzymologically modified, either acetylation or adenylation or phosphorylation. Now, there's this word cross-resistance. I don't know if I mentioned it before, but cross-resistance means that if you have a bacterium that is resistant to a certain antimicrobial, it's very much possible to be resistant to another antimicrobial from the same class. For example, if a bacterium is resistant to gentamicin, it's possible that it is also resistant to tobramycin, netilmycin, and amikacin. And a typical example of cross-resistance that I failed to mention before is the beta-lactamases, right? So if you have a beta-lactamase that leads to resistance to amoxicillin, most probably you also have ampicillin. Resistance to ampicillin. Of course, there are different beta-lactamases, and we talked that some antimicrobials are more resistant to the resistant factors, and we talked about the cephalosporins, etc. Now let's go back here. So we have cross-resistance, but not always. Let's follow this site here. So if the bacterium leads to acetylation in here, on gentamicin, it's going to lead to acetylation in here also on tobramycin. It's going to lead to acetylation in here also on netilmycin, and it's going to lead to acetylation in here on tobramycin. So yeah, that bacterium is leading to cross-resistance for all 4. However, if we have, let's say, let me see, here, if we have acetylation on this site, the bacterium will be resistant to gentamicin, it will be resistant to tobramycin, it will be resistant to netilmycin, but it will be sensitive to amikacin. So you see those blue X's, it means that there is no resistance, and you can see that there are a lot of X's on amikacin, and for instance it's the one, if you want, the strongest, the one that is associated with the least resistance. And as you can see here, it's written X is protected from the enzyme. You have seen this so many times by now. We've heard of aminoglycosides before, and those are only for gram-negative bacteria. And we've heard of them when we mentioned Astrionam. Remember, Astrionam is a beta-lactam, it's the monobactam, and we called it the non-aminoglycoside aminoglycoside. Why is that? Because they both cover gram-negative bacteria only. So some characteristics on microbe interaction with aminoglycosides. So we said gram-negative only. Also specifically the aerobic ones. Why? Because we said that those are polar drugs. You need active transport, and for the active transport to work you need oxygen. So those work only on aerobic conditions. And also here we has a post-antibiotic effect, a PAE, and we introduced that before. We talked about it at length when we were talking about the beta-lactams, and we also mentioned it in the fluoroquinolones. And here it comes again, post-antibiotic effect. And remember, we said that this helps us to space the doses. And we're going to see a beautiful pharmacokinetic application now because of the PAE, and another thing, and that is concentration dependent killing. We also talked about concentration dependent killing, and we said that this mainly happens with drugs that work inside the bacterium. Another interaction, they are synergistic with beta-lactams. We use them only for serious hospital infections because, as you will see in a couple of slides, one, they are toxic, and we already guessed that they are nephrotoxic and ototoxic, and also they're given IV. Why? Because they are polar drugs. So they're given IV, they're given in the hospital, and they have to be serious infections because they're really toxic. So we do use them in combination with beta-lactams because of the synergism. Rarely used alone because of toxicity. Note that when we use them with beta-lactams, we really don't want to put them in the same bag because they inactivate each other. So you have two different bags, one for the beta-lactam and one for the aminoglycoside. We've seen this slide before, and this is tobramycin and this is ticarcillin. You may remember that ticarcillin is an anti-pseudomonal beta-lactam, and what you see here is time-dependent killing, and this is tobramycin, and which is an aminoglycoside, and you see this beautiful concentration-dependent killing. We have mentioned toxicity many times before, but now let's discuss it in more details. So I mentioned nephrotoxicity, I mentioned ototoxicity, and this I haven't mentioned before, it's neuromuscular paralysis. Let's talk about that in a minute. So this is exceedingly rare, and it happens because of inhibition of prejunctional release of acetylcholine, and it can happen if we give the infusion really quickly, in less than 5 minutes. So you really don't want to infuse aminoglycosides very fast. You want to use a Baxter for that. And this also can happen in people who already have myasthenia gravis or taking neuromuscular junction blockers. Now, concerning nephrotoxicity and ototoxicity, what happens here? We have disruption of the cytoplasmic membrane. Remember, we said that we have the aberrant proteins, the wrong amino acid. This might affect the membrane of the bacterium, but also it could affect the membrane in the kidney because it is concentrating there. This is relatively common, and you see this range from 0 to 50%. It really depends on the definition. What kind of a clinical trial are we talking about? Are we measuring serum creatinine? Are we taking urine analysis? Are we collecting urine for 24 hours, etc.? We do have proximal tubular changes in all and some glomerular changes, rarely severe, and the nice thing is about it is that it's reversible. So it's relatively common, we monitor for it, but rarely severe and reversible. The problem really is ototoxicity. Again, here you have ionic imbalance and destruction of cells, very similar. Luckily, it's uncommon. It could be both cochlear and vestibular. Yeah, it could lead to hearing disturbance or vertigo and tinnitus. The big problem is that it is irreversible. That is the main problem with aminoglycosides, potential for irreversible ototoxicity, although it is rare. Clinical features, we said that for nephrotoxicity, we want to monitor with serum creatinine. You will see a decrease in glomerular filtration rate. When you take BUN creatinine, you will see that it is increased. If you take urine analysis, you may see phospholipids, you may see CAS, you may see proteins, you may see hypoosmotic polyuria. For ototoxicity, sometimes we don't have clinical features. But when we do, we may have tinnitus, so this is the vestibular, and we may also have cochlear, and that is low frequency hearing loss. It starts as high frequency and then move to low frequency, so the patient may not really feel the hearing loss until when it becomes advanced. Hopefully it won't become advanced. Also for the vestibular, we have a sense of imbalance, vertigo, we may have nausea and vomiting. Again, we said potentially irreversible and cumulative. What I mean by cumulative is that the more we take aminoglycoside, the higher the chance of having tinnitus. And this is why the person maybe starts with high frequency hearing loss, and if we continue on taking aminoglycoside, then this will shift to low frequency hearing loss, and this is when the person doesn't hear anymore. And even to make things even worse, and that is we may have some progression even after cessation of the drug. So this is very bad. So now we want to try a strategy, the dosing strategy, to hopefully decrease the risk of ototoxicity and nephrotoxicity. So when we start an aminoglycoside such as gentamicin, we start with a loading dose, whatever the loading dose is, and then we move to the maintenance dose. In the past, when I was a medical student, we used to give 1.5 milligrams per kilo every 8 hours, so 3 times a day. Whereas now, gentamicin is given as a maintenance once a day, 4.5 milligrams per kilo. Now, if you look at the dose, it's really the same one. This is 1.5 times 3. The only difference is the frequency. This is 3 times a day, and this is only once a day. What are we trying to do? Remember, I'm trying to decrease the risk of ototoxicity and nephrotoxicity. Before I explain what's happening, I want to remind you of those concepts that are written here that I already mentioned before. We already said that we have concentration-dependent killing, right? So the higher the concentration, the better killing. We already know that. 2, we already discussed that we have a post-antibiotic effect. But I failed to mention something, and I'm mentioning it here, and that is this post-antibiotic effect is even higher with higher concentrations. So the higher the concentration, the more we have a post-antibiotic effect. And then this is important. Uptake into the proximal renal tubule cells and the inner ear is saturated at low plasma concentration. We said that the drug concentrates there, and it concentrates there really fast. So when you give the drug, this is where it goes and sits, and it saturates there. This is very important. So here you go. Let's go over this very slowly. This is what we used to do in the past, and this is what we do now. In the past, we used to give a lower dose. As you can see, we are reaching a less Cmax and at more frequent times. So here we were giving it every 8 hours, but now we are giving a much higher dose that is reaching a much higher concentration, and we're giving it only once a day. And this line here, don't worry about the number, the 2 micrograms per ml, it's not important, but know that at this line, this is where the drug reaches saturation in the ear and in the kidney. So anything above this line, any concentration above this line means that the ear and the kidney are saturated with the aminoglycosides. And anything below this line, means that the drug is leaving the ear and is leaving the kidney. So this is good. Remember, what is our aim? Our aim is to protect the ear and protect the kidney. So we really want to have the concentration of the antimicrobial below this line as much as possible. This is our aim. I want the drug to be below this line as much as possible, but then of course I want some effect. I want to kill the bacterium. So if you look at this strategy, you have very little time below this line. Whereas here, with this strategy, you have this long time below this line. So hopefully we'll have less nephrotoxicity and less ototoxicity. But are we killing the bacteria? Hopefully yes, because what we have done, one, we gave a very high concentration, right? Very high dose. Because of that, we're reaching a very high concentration. And we said that we have concentration dependent killing. The higher the concentration, the more the killing. So yes, we are killing a lot more here because we're reaching a super high concentration. This is one thing we did. Two, we have the post-antibiotic effect. You see here, this white color here is the post-antibiotic effect. And we also have it here, this post-antibiotic effect. But the difference between here and here is that because the post-antibiotic effect is concentration dependent, it is even longer. So here we have even a longer post-antibiotic effect. What do I mean? I mean that here, even though the concentration of the drug is low, still the bacteria are dying because of this PAE. So we are left only with this tiny green area where we have no effect at all, and here the bacteria may grow again. But it's okay because we have already killed so many by this high concentration here and by this prolonged PAE. So what are we trying to do here again? Let me summarize. We are trying to decrease nephrotoxicity and ototoxicity by having a concentration below this line as much as possible without affecting the effectiveness of the drug, and we are comfortable with that because of the concentration dependent killing and the concentration dependent PAE. What else have we done? Another thing we have done is the practical. So here we used to give the drug 3 times a day. Now we give the drug once a day. And here we used to take peak and trough. What do I mean? So once you give the drug, you would call the phlebotomist and to take a peak level half an hour after the dose to make sure that the Cmax is high enough so that we have high enough killing. Now with the new strategy, you don't need to do this anymore because we are giving such a high dose, we are sure we are reaching this high Cmax. So you see it here, efficacy, peak, toxicity, trough. This is not in bold, this is bold because we don't do this anymore. We used to do this in the past. However, now and in the past, we do the trough. What I mean by trough is here, right before you give the second dose, I want to make sure that the concentration is really below this line, 2 micrograms per ml. If it is above, then maybe I may space the drug. I may give it later, or I may give a lower dose. Why is that? Remember, I want to stay below 2 micrograms per ml as much as possible to prevent ototoxicity and nephrotoxicity. So let's see, did this strategy make any difference like the way we explained it together now? Yes and no. Luckily, no difference in clinical efficacy. So yeah, we are still killing the bacteria, we're good on that front. However, ototoxicity not different. It really didn't matter. And nephrotoxicity, maybe reduced nephrotoxicity, but we're not that sure. But still, we now use the once a day dose because it's the same efficacy and the additional benefits that I mentioned: convenience of once daily dose, reduced cost of drug administration. You don't need to have a lot of IV bags and etc. And now we don't do the peak concentration anymore, we only do the trough concentration. What are clinical uses of aminoglycosides? We already agreed that they are toxic drugs. We don't use them alone. We keep them for aerobic gram-negative bacilli. We can use them for synergism for some aerobic gram-positive cocci, such as staph and strep, but this is with penicillins because there is the synergism. And by the way, we can also use them as second line for tuberculosis. For instance, streptomycin can be used for that, and we have also some rare applications. And finally, this slide is definitely not for your memory, but I put some details here just for your interest, because you will see those drugs and for you to know a little bit which is which, etc.